So again, the information gathering will depend on the differential diagnosis, and there is wide range of differential diagnosis in this case. Then the history will be according to the differential diagnosis, the general and abdominal examination, the investigation. The risks in this case, this is a case of ovarian tumor. This is by itself is a risk. Debulking surgery is difficult and prolonged surgery. There is vomiting and distended abdomen after the surgery. This is another risk for possibility of paralytic ileus, possibility of bowel or other organ injury. So what you are going to do here in this case, with the first possibility as a paralytic ileus from the prolonged surgery and the bowel were exposed for a long time, so this is the first possibility. So MBO, nasogastric tube and conservative management, and start the sepsis protocol. After taking all the cultures, you will start the antibiotic after 1 hour of excluding allergy, start the IV fluids, start input and output chart, communicate with your consultant, multidisciplinary team involvement, communicate with the patient herself and the family, and the thromboprophylaxis. And finally, documentation. The files are not there, so please don't forget the documentation. So this is, Dr. Wafa, you mentioned everything, but again, because you are under stress, you didn't mention the first thing that will come in your mind if you are thinking in the patient as a normal patient in your ward round. So once you forget the case and you start thinking while you are relaxed, the first thing that will come in your mind is paralytic ileus and possibility of bowel injury. Is that clear?
Yes, doctor. If in exam that happened to us, that will reduce our marks or to fail or something?
There are.
If I manage the patient as a sepsis, like
I told in the beginning. I don't know if you were there or no. There are key points. I will repeat it again now. There are key points in this station. If you mentioned these key points, it means you will not fail in the station. You will have borderline or pass. So your mark will depend on the key points. If you mention the key points, you will not fail. The least mark you will have, it will be borderline. From borderline to pass, it will depend in your amount of stress. If you are thinking in relaxation, if you are thinking as Dr. Wafa is thinking in her usual daily round, you will definitely pass the station because it is easy. It's basics, all basics. Okay, so I will mention again the key points, but after the fourth case. Who will take the fourth case?
May I take? Can I try?
Yes, please, your name?
My name is Razia.
Yes, Dr. Razia, go on. You have 2.5 minutes for this case. Please remember the key points if you attended from the start. Start.
Okay. Yeah, this is a I'm Dr. Razia. I will just go into the room after following the infectious control measures. I will sanitize my hand and wash my hands before touching the patient and after leaving the patients. This is a case of post-laparoscopy salpingotomy for right tubal ectopic pregnancy. So first I need to ask how is patient's recovery, how she is doing. Does she has any concern? Because here not written patient is having any complaint or any concern. Her vital signs what are mentioned, they are normal. And urine report is also mentioned, which says there is no abnormality. So I will see patient's notes also, and this is before she has also previous salpingectomy, and this is salpingotomy. So it will be very distressful for patient as she is very young, 24 years old, to lose one tube and the other tube also affected. So maybe she will be psychologically distressed. I will first review her and talk to her and try to counsel her, and then ask her reviews. I will also check her blood group. And if anti negative, then we'll give anti-D and see histopathology has been sent for her or not. And then she is a salpingotomy, so I will advise to follow beta ICG weekly till it becomes normal. And does I have any information about this case? Because I don't have notes, so I will check with the nurse. Any specific, she has any notes with her, so I want to know the case a little more.
No information.
Okay, so I need to know, like, any risk factor she had for ectopic pregnancy, and does she has any children or not? And I will advise follow-up plan, because this patient follow-up plan is important and counseling is important. And if she does not get pregnant next time, then she needs to do HSG or diagnostic laparoscopy to see the patency of tube, and that counseling is very important. And then we can arrange for her in future to follow, and proper follow-up is important in this case. And if tubes are affected, then maybe we can offer her IVF, and partner counseling is also important. So
Okay.
also examination, I would like to also examine her, like how is she. Actually, it is straightforward case, so I don't understand, like.
Yes, it is straightforward. The case you managed to start a very, very marvelous start, Doctor. I'm sorry, your name again? I'm very bad in names. I'm sorry.
Razia.
Dr. Razia, you did a very good start. Actually, it's very impressive. But by the end, because the case, there is nothing in the case, you started to think what I have to tell, and you forgot a very important point. What are the red flag signs for this patient to come back?
Follow-up of beta ECG, follow-up of this histopathology report,
exactly,
and future risk of ectopic pregnancy, and
exactly.
diagnostic laparoscopy if it is she has any difficulty in conceiving.
Okay, so this patient is completely normal. There is nothing, no issues in this case. Only the patient has laparoscopic salpingotomy, so there is possibility of persistent GTN. So you will follow here HCG, and this patient may need another surgery, or she may need the methotrexate. So she has to have a proper follow-up. You managed to remember the NTD, which is a very important safety point in this case. If you didn't mention it, it will be fail in the safety. Okay, so also in the future pregnancy, you will advise her what she needs to do. So this case is a straightforward case. Don't get disturbed in the exam because you don't find anything to say. Again, you are in the ward, you are doing around for this lady. She's normal, nothing to be done. So the patient is stable. So you will explain the operative finding and the procedure for the patient. You will give her the follow-up plan regarding the HCG. She will repeat it after 1 week, then the follow-up and the possibility of methotrexate and the surgery. Check the blood group for RH and the possibility of NTD, and the future fertility plans and the contraceptive choices. And remember to mention the red flags that she has to come back for it, like bleeding and pain. And in the future pregnancy, once she knows that she's pregnant, she has to come for early ultrasound. The risks and the problems in this case may be adhesions due to the previous surgery. Laparoscopy itself is a risk. Risk of recurrence, again, because now the patient has only one tube and she had salpingotomy, and the risk of persistent GTN and the need for further surgery and methotrexate. This will be the answer. If you want to be more organized, you can say the condition of the patient at first. Then the next question, what are the risks and the problem in the case? You can manage, as I told you, each box in the table, you will find the risk factor there. So be more organized, go step by step. You will do it very well. Actually, you did very well, but remember, any patient that's stable and going for discharge, the red flag signs, please. So again, the key points that I mentioned at the start of this station. All of you, you have to introduce yourself to the patient, please. So I will follow the infection control measures when moving from one room to room. I will introduce myself to the patient, and I will put in mind as a possible differential diagnosis. I need to review her notes. Then according to the differential diagnosis, I will search for the missed points in the history, especially the recovery time after the surgery. I will do relevant examination according to the case, do the relevant investigation according to your suspicion, according to the differential diagnosis. Then please remember the thromboprophylaxis, the drug allergy. If you are going to give the patient any treatment, just add the drug allergy to any drugs you will give. If you are thinking about blood transfusion, discuss the patient concerns regarding blood transfusion, if she have as witness or no. Involve your consultant if there is any problem, and remember the 7 Ds in case of complication. What are the 7 Ds?
Yeah, the documentation and
Documentation,
debriefing,
debriefing,
and debriefing of the team, and dietetics, risk management, drill, risk management, and staff drill.
Duty of condor.
Yeah, duty of condor also. Yes.
What else?
Discuss with patient, discuss with colleague.
Yes, discuss. This means with the patient, debrief. Colleagues, discuss means auditing and risk management and reflective practice. Okay, then discharge. Okay, so these are the 7 Ds that you have to mention in each case with complication. It's very important. Okay, so this is a way how to approach a case of post-operative gyne round. These 13 points, these are the key points here in the station. If you mention them, you will not fail in the station. You will not fail under any circumstances, because these are the failure point in the station. But if you mention them, either borderline or pass, it depends on your performance, and it depends in the amount of stress you are putting yourself in during the exam. So relax, breathe, relax. Each one of you, once you will go through the table again, you will feel that you did unnecessary mistakes. You forgot unnecessary information. Okay? Is that clear?
Yes.
Okay. Any
yes,
questions?
Doctor, clear.
Any questions?
Doctor, I have one question regarding the room number 3, the BSO. In that case, because she has risk of breast cancer, so what HRT we will give her?
No, here, don't give the information. Don't give the information.
No, because if in that case, if we are assessing the HRT, like we are talking about it, then what we will talk about, or we will not talk
just say that this patient has to do breast exam regularly, and this patient has to follow up in the menopause clinic. This is a high risk case. It will be done by the menopausal clinic and the menopausal specialist. Don't go in details. Don't start here. Don't open a long discussion, which is unnecessary in this case. Just take the point and escape. If you will open and start saying this patient is at risk of breast cancer, so we cannot give progesterone, because you will put yourself in trouble and you will lose the time for unnecessary information. Just mentioning that this patient will need HRT for replacement, and you will need regular follow-up breast exam, and the better you can, if you want to add, you can add the menopausal clinic. That's all. That's all. Okay.
Okay. Thank you, Doctor.
Don't give information here, because it's unnecessary. This is not needed here. If you have a menopausal station or menopausal discussion or simulated patient task, you can consider this if the patient has history of BRCA1 gene mutation, or she has history of abnormal cancers before. So at this point, you may tell what kind of hormone you will give and what you will not give. But here, there is no need. Okay? Please don't forget the documentation, please. Please don't forget in any patient with fever to give a hint about the COVID symptoms and the COVID vaccine. Is that clear?
Yes, Doctor.
Okay. So this is the first.
Can you, Doctor, hello? Can
Yes.
you just show me that slide number 1, please? Room number 1.
Room number 1, I'm sorry. Room number 1. What's your question?
No, I joined late, so I just wanted to see the answer, that answer slide.
Yeah, you will have the recording. I will post the recordings.
Okay, thank you so much.
On the,
Yeah,
on the
thank
group.
you.
Okay. Okay. So this is the first station. Now we will go to the discharge summary. Did you listen, all of you, to the lecture about the discharge summary?
I did.
Okay. Do you feel that this lecture changed anything in your approach?
Yes, Dr. Surur, it was very good because there are so many things that we don't know being overseas candidates. So it was really very good because we got to understand their way of doing all of those things. Though you were right, we all of us are doing in our own setups, but we must know the difference.
Yes, that's exactly was the aim of this lecture. I felt that the people are going for fixed phrases. They don't understand what they are telling. So it was better to understand the process of discharge, what you need to say, and what are the important points. I stressed during the lecture about some points. Please take care of these because this will be a questions in the exam. Most probably, if you didn't mention it, the role player or the junior colleague will ask about it in the exam. So,
excuse me, Dr. Sarur.
Yes.
Please, can you give us mark according to the domains? Then we'll get some, how to improve. We can see our level, please.
See, Dr. Salma, I will not give any feedback again on public. Okay, so next time, if you want feedback or evaluation of your performance, it will be in private. Okay, because I felt very bad last time after giving the feedback. I felt I was harsh. No need to give the feedback in front of the other candidates. So next time, if you need feedback, I will give you in private. Okay.
Okay. Thank you very much.
You're welcome. You're welcome. So now the discharge summary. I need someone new to do.
Can I do?
Your name?
Salma.
You are not new, Dr. Salma.
All right. Okay. If anybody.
Yes, if anyone is interested, we'll give the chance for everyone. If anyone is interested, he will start. If no one is interested, Dr. Salma will take. Anyone? Please be brave to do it. You will get rid of your fears once you start talking in front of the others. No volunteers?
Hello?
Yes. Finally, yeah, finally a man. Okay. Okay. Name, please. Okay, Dr. So, Dr. Sharif, you will have 2 minutes for reading. Actually, in the exam, it will be 2.5 minutes, Dr. Sharif. But here, to put you under stress to finish as soon as possible, it will be only 2 minutes. And please, there is another page for the instructions. Ask me when you want to change the screen. Okay, start.
Okay. Okay, next. Okay, the previous one.
Okay, 2 minutes, Dr. Sharif.
Okay, thank you.
Before starting, what is the situation awareness now, Dr. Sharif? To make it easier, what's the situation?
This patient was admitted as having right-sided abdominal pain, and she has undergone investigations, and it was diagnosed as right tubal ectopic pregnancy. Laparoscopy was done for her, and right tubal self-injectomy was done for her. After that, the patient is stable and planned for discharge.
This is regarding the patient. What about the station itself, the core of the station?
The core of the station, he needs to, he wants to know more about the communication with colleagues and if there is any problem with the discharge summary, and to teach how the FY1, how to write a safe discharge summary for the patient after doing the surgery.
So what's your agenda?
My agenda, first of all, I need to check the candidate's concern and why he's interested in this discharge summary, and why he was referred to me, and then explain for him how to go through this discharge summary step by step, and then provide him with the learning plans and create a report with the candidate as well, in order to know what is his weak points, what have been done, what have not done better, and what could be done better in the next discharge summaries.
Okay, perfect. So, Dr. Sharif, you will have 10 minutes starting from now.
Okay. Hello, I'm Sharif, ST5 here. And you, Sam?
Yes, I'm Sam.
So how's everything in the department, Sam?
Actually, I joined only yesterday. I have my introduction interview, but really I'm interested in Obs and Gyne. So I'm trying my best, and today the midwife asked me to write the discharge letter for this lady. So I wrote it, but now she's calling me to talk to you. Is there anything wrong I did?
Actually, you have done a nice discharge summary right here. I can see, and I have gone across through it. However, the midwife may be a little bit worried about some points that all of us have been missing in our beginnings of training. So if you allow me, in the next few minutes, I will have a little chat with you to tell you about the most important points in the discharge summary. And at any point during our discussion, hopefully you can stop me at any time to explain for you more. How does that sound for you?
Yeah, that sounds great. Thank you.
Okay, so at the end of our discussion, I will provide you with the learning plans, so how to write, to know more about writing discharge summary. I will provide you with a performa, an already written performa for many of others who wrote this discharge summary to know more about it. And again, I will arrange another meeting if you have any further queries regarding this issue, okay?
Yeah, that's nice.
So let's start, So let's start first by what is the main aim of discharge summary. Discharge summary is mainly to ensure continuity of care for the patient after being discharged, and to ensure the implementation of the 7 pillars of the clinical governance as well. However, also it is important for the medical legality implications in the future, in case if the patient have any complaint or unsatisfied by the quality of service offered. So can you repeat after me, what is the importance of the discharge summary?
Yeah, you said it ensures the continuity of care and it can be used in clinical governance. And
yeah, excellent, Sam.
Yeah, thank you. Thank you.
You are a fast learner. Okay, so I will tell you the components of the discharge summary in brief, and then we will go together to the scenario that you have seen here and this patient that you have discharged and explain on it. Okay?
Okay. Okay.
Okay, so this discharge summary, usually usually we are caring for the demography of the patient to write the address, name, together with the name of the consultant and the name of the unit and the name of the hospital, the name of the GP as well has to be addressed in this demography. And then we go after that for the discharge summary criteria. It should be clear, illegible, containing patient-friendly language, avoid abbreviations. All these criteria should be addressed to the discharge summary. Am I clear till this point?
Yeah, that's fine.
Then we need to write some points about the history of this patient, few history just to know if there is any allergy, any comorbidities with the patient, how was the referral mode, was it coming from the A&E or coming from the ward, what surgery has been done, and any investigation that need to be done, any awaiting investigation. And there is also something called the extended discharge summary after the primary one. We need to address also the date of admission, the date of discharge, and the primary diagnosis and the final diagnosis as well. And at the end of the discharge summary, we need to type the phone number and the plate number, and stamp it by me and by you and the consultant as well. And 3 copies will be provided of this discharge summary, one for the GP, one for the patient, and one for the hospital record. Am I clear till this point?
Yeah, that's clear. So at what time I need to write the discharge summary?
Yeah, so can I please see the, can I show you here, to see this discharge summary? Yes. Okay, so it's very nice from you here, Sam, that you wrote the patient name here, but wouldn't it be better if we wrote also the address of the patient and the NHS number, as I can see here?
Yeah, you are right. I'm so sorry that I didn't mention that.
No worries about that. And also the hospital number is perfect that you have written here. Again, we need to add on also the GP address and the GP name as well, and the consultant name as well, together with the unit, the name of the unit as well. So this is what we call the demography, as I explained for you before, okay?
Okay.
Now here, the patient has been admitted as an ectopic pregnancy. In the summary, you need to mention from where she came, either the A&E, or if she has been already admitted in the ward or admitted from the outpatient. So we need to know the role of the admission here. How was the situation of the patient upon admission? How are the vital signs? Was any ultrasound done for her? I mean, all the investigations and the findings that have been taken on the patient upon admission need to mention in summary in the discharge summary as well. Okay?
Yeah, okay.
In the notes here, there is a laparoscopic salpingectomy, just to need to give an idea about what was the vital state of the patient, consent of the patient, consenting, and that the minimal information only about the operative details, and that she was stable. And after that, you wrote here, fit for discharge 24 hours after the surgery. So we cannot here, Sam, suppose that the discharge of the patient to be after 24 hours, unless the patient is totally vitally stable and complete recovery of the patient. And you mentioned that you have debriefed the patient as well and explained for her all the events that happened?
No.
You have to mention here in the discharge summary as well that we are waiting also that you have explained and debriefed the patient, and if there is any difficulty during the surgery, and that the tube and this right salpingectomy have been done to her, need to be explained for her, and also need to explain for her an appointment with the consultant lead unit, because this patient have done a histopathology report is awaiting. So we need to confirm the final diagnosis for her as well. Am I clear?
Yeah, that's clear.
At the end of the discharge summary here, you say no hospital follow-up. Well, this patient actually need a follow-up, Sam, to know the result of the histopathology and to repeat the beta HCG as well hormone in order to ensure complete resolution of the condition and provide her also with contraception because she is now at high risk of having again an ectopic pregnancy. So the complete follow and the VTE prophylaxis. And you also need to mention the medications, Sam, about what to continue, what to stop, what new medication, allergy should be excluded, the dose, the prescription, all this should be written in a proper organized way in the discharge summary.
Okay. So,
okay, Sam. So
what is the time limit I have to write the discharge summary? Can I write it later?
Well, if the patient is still here in the hospital, you can write, you can modify these informations in the discharge summary if the patient is still admitted and re-counsel her again and debrief her that we might need to keep her for 1 or more 2 days to be sure that she's in the best possible shape before her discharge.
Okay, so if I'm going to send the discharge letter to the GP, what is the maximum time to send it for him?
Usually, the maximum time is usually 1 week. However, it is not up to my mind at the moment, but I will check with my consultant and with my midwife about the accepted time frame to send for the GP.
Okay, thank you.
I hope this have, you are getting use of this chat. So how did it go with you?
It was very fine. I got a lot of information, actually. Too many information to go with today.
Yeah, I will give you this discharge summary again, another formatted one already. I forgot to mention you that sometime we might need to individualize, it might be individualized and given in handwritten. But sometimes some units may make it in a plotted pro forma so as not to miss any information for the patient. Thank you, Sam. And at any time you see me here or anywhere, you can stop me and ask me if I have forgotten something, and we can talk about it again.
Okay, thank you so much.
Thank you very much.
And stay safe.
Thank you.
Thank you. Very well done, Dr. Sharif. Even before the time, 9 minutes and 30 seconds, you managed to say everything. I don't have any comments, very minor comments. It will not change anything in your performance in the station. Just say nice to meet you at the beginning. Don't go directly. And nice to meet you. You mentioned Sam, how things are going in the department. So it will be ice-breaking if you say nice to meet you at the beginning. And try to avoid you should or you have to. You should or you have to, it will be a little harsh. Okay. So don't you think it will be better if we do it like this? So better to avoid this. At the end, you still have time. So if you can mention that, I will give you some articles about the ectopic pregnancy and some ready performa, but you already mentioned
yes.
You already mentioned it in your agenda at the beginning. So agenda is very important. That's why you will not miss this point. This point already taken from the beginning. So even if you didn't mention it by the end, you already take the point. So very, very well done. Very well done. Thank you, Dr. Sharif.
Thank you, Dr. Lazar. Thank you very much.
So here the introduction was nice, making a good report. Just to add, nice to meet you. Check for bullying, but this candidate is a fresh candidate only. He had his introduction interview yesterday, so it's not a place here. No blaming atmosphere, as exactly what Dr. Sharif did. He said no at the beginning, we will do this. The aim of the consultation, the emphasis on the importance of the discharge letter, the background, you can add here if the candidate knows about the case or he's following the case or no. Then the agenda, and then you will go through the steps. As we mentioned, the demographic data, the date and time of discharge. If you want, you can add the summary statement at the beginning. Then the style, you can, besides the handwriting, you can add, it can be written in bullets or in a story. Am I clear so far? Am I clear till this point? That was very good to keep the candidate engaged during the discussion. Excellent, that's enough. Excellent. You are praising him without wasting time. too much time and you are a very fast learner and these phrases. What do you think in between? What are the additional information here to be added? This is the only point that missed in the station. If this patient, her blood group is negative, it was written in the notes. This is the only point, this is the only major point in the station. Otherwise, nothing at all. So if you manage to mention the A negative, because this patient may need anti-D later, this is a point of safety. So regarding the procedure, the name of the procedure and the date, and if there is any complication, the discharge condition the patient is stable, the red flags that the patient has to be mentioned during discharge when the patient has to come back. Again, any patient post-operative, please remember, any operative case, don't forget the red flags. Then if there is any instructions regarding the activity and the treatment, then the follow-up. You close the station in a very nice way. How was it? You are checking his feedback regarding your way of teaching. And you already mentioned at the beginning the articles that you will give to him. And please, again, articles, not leaflets or guidelines. Guidelines or articles, not leaflets. Leaflets only for the patient. Okay, very well done, Dr. Sharif. Only few points.
This entity, I feel it can come discharge summary too long like this. I was only scanning the paper. I'm not reading every word.
So what do you think in patient? That's what I said. From the beginning, look at the discharge summary that you wrote at the start. After reading the instruction, go directly to the discharge summary. See what's missed here. What's missed in demographic data, in the history, examination, investigation, and in discharge. Patient after ectopic, what do you want? You will ask her, in your daily practice, I need to know her blood group. So if you go back and you check her blood group, you will find here the blood group is A negative. Okay, so you don't have to read everything. You don't have to read everything here, but this point has to be added because it is a point of safety. Okay.
Yeah.
Okay. Thank you, Dr. Sharif. Very well done. Very well done. And at the end, if you have time, you can again add anything at any time. No one will tell you your time finished. You have your time. You can say whatever you want. Okay. Thank you, Dr. Sharif. Very well done. Thank you, all of you. Next week, inshallah, I will do the session for the pre-operative gyne list because this is a repeated station that everyone wants to do it. So I will do it next week, inshallah, and I will announce in the group when we are going to meet. Any questions?
You will share the recording?
Yes, I will share the recording, inshallah.